This is Chapter 8, and it's all about seizure disorders. A seizure, a temporary episode of behavior alteration, and it's due to massive abnormal electrical discharges in your brain. So a seizure can usually be recorded on an EEG to determine what type of seizure that it is. It may be accompanied by convulsions or other neurological, sensory, or some type of emotional changes. A CNS dysfunction is usually what is in order here. Central nervous system dysfunction, alteration in the state of consciousness sometimes, motor activity, your sensory phenomena with sudden onset and a brief span of activity. So it can be caused by systematic distress. You can have isolated, non-recurrent, attacks that don't happen, once a week or something like that on a systematic way. It is very isolated. So you could have hypoxia, which is deficiency of oxygen reaching the tissues of the body. Hypo is less than normal, and oxia is oxygen. So you could have a deficiency or very lower than normal oxygen reaching any of the tissues of your body, putting it into a seizure. Hypoglycemia, you have that patient that has blood sugar less than normal sugar in the blood, then it could, and it's, you don't give them anything, it could throw them into a seizure. So it can be caused by damage or disease to the brain. It can be caused by trauma, tumors, perinatal injuries, toxins, infectious agents. If you have an electrolyte imbalance, uremia, drug withdrawal, or sedative hypnotics or vascular disorders. Seizures, they have a genetic tendency in some families. It doesn't mean that there will definitely be a genetic relationship, that it will always be hereditary, but there is a tendency in some families. Half of all the seizures are idiopathic. Idiopathic is the word you'll need to know throughout this program. It means it has an unknown cause. It's pathic is kind of the cause, and the idio is the unknown part. So seizures, they have, if you see certain words called ictus, ictal, postictal, aura, they all refer to a seizure. Epilepsy. Epilepsy is a group of disorders involving chronic, recurrent, definite recurrent attacks, and there's involuntary behavior and changes in the central nervous system function. So it's a very common disorder. They say even at the time of this printing of this book, there was about 2 million in the United States. And seizures, most common are neurological disorders in pediatrics. First seizure usually appears before age 20. Seizure is not a disease either. It is just like syncope. It is a symptom of a central nervous system dysfunction. But you don't have a disease, could be epilepsy, but you don't have a disease of seizure. Just seizures often happen with when you have other central nervous system dysfunctions. So they're classified, all seizures are classified by their cause. So in other words, their etiology, symptom, duration, if they have an aura or not, and any other precipitating factors. They are categorized based on those. So usually seizures are not life-threatening, but death can occur most certainly with seizures. There's several potential causes or etiologies. In the dental office, You could have hypoglycemia, which could lead to a seizure. If you remain in a fainted stage for a long time, it could cause a seizure, or syncope rather. Hypoxia, not getting enough blood, secondary to syncope. Local anesthetic toxicity, if you have just way too much local anesthetic and to a toxic level, that could be a problem. And we never give in the dental office just, cartridges and cartridges and cartridges of local anesthetic. The local anesthetic toxicity that this is talking about is that local anesthetics are metabolized in usually the liver or the blood, and they're excreted through the kidneys. So if you have something, if you're an elderly person or not, and you have something majorly wrong with your kidneys, so you're not excreting this out of your system in a normal rate, and there's something wrong with your liver, so it's not metabolizing, it's just staying pure in your system, you have a better chance for local anesthetic toxicity, and that's what it's talking about. And of course, epilepsy can produce seizures. So types of seizures, it is usually determined by the EEG pattern. Some patients even have more than one type. You have your tonic-clonic is the most common type of seizure disorder. You need to know that. The tonic part is the sudden stiffening and muscle contraction. You just suddenly stiffen, and the clonic part is where you get the twitching and jerking in kind of a rhythmic way. There's also something called photosensitive epilepsy. It's when children are exposed to flickering lights and like maybe video games. It can give them kind of a seizure type of photosensitive epilepsy, they call it. So types of seizures, here we go. You have your partial. Partial seizures are divided into two different types. One's simple and one's complex. The simple partial seizure, it has no loss of consciousness. So you have a little seizure, but you are with the program. And you can have an aura, deja vu, which is a feeling of something that's already happened is happening again. Flashing lights, illusions, vertigo, creeping feeling, tingling, foul smells, and amnesia afterwards. You can have jerking and stiffening. So partial seizures, you can have all of that, but you're not unconscious. Complex partial is with the impairment of consciousness. So you have you lose contact with all your surroundings. It could only be for a few seconds, up to like 20 minutes. You might be doing repetitive things, clicking your nails, tapping on something that's repetitive, lip smacking. Your speech can be altered. You could be walking in circles, just in repetitive ways, and there's mental confusion. But like I said, you may even still be sitting up, but you are not there. You have an impairment of your consciousness. You're not completely unconscious, but you just kind of lose contact with your surroundings, and you're kind of somewhere else. So generalized seizures, electrical abnormality throughout the brain can cause generalized seizures and a definite loss of consciousness. So often this is genetic or have a metabolic cause. Recurrent generalized seizures, good example is epilepsy, because they don't just happen isolated. Every once in a while, it's something that particular things can trigger, maybe seizures. Types of generalized seizures can be tonic-clonic or absence seizure or febrile seizure. And they always go in a specific sequence. All of those, tonic-clonic, absence, febrile, these generalized seizures. First, you have an aura, which can be a few seconds. You can have the same one even all the time, but you have amnesia afterwards. I always thought it a little odd that how do they know you're having the same one if you have amnesia afterwards, but that's just me. Okay, then we have preictal, which you lose consciousness in the preictal stage. You have an aura and then preictal. Then you have your ictal. That's when you have your tonic-clonic movement with the stiffening and the jerking. You can have a cry, have froth. You could have froth in the mouth. It can last anywhere from 2 to 5 minutes with a very final big flexor jerk. And then you have postictal. So that's when it stops. You can be unconscious. Central nervous system and the cerebrovascular system and respiratory depression. If you have that, death is most likely. But a lot of times it stops and you can come right out of it. So it's a lot of the ictals. It's the aura. Then you have preictal, ictal, and postictal. The postictal phase, right afterwards, you have complete muscle relaxation. You could go to the bathroom. Sometimes you have urinary or fecal incontinence because your muscles are so relaxed. The patient awakens, they're confused, they may be really super tired and want to go to sleep, and they have amnesia. They don't realize what happened while they were having this. It can last for minutes to even several hours on this postictal phase. So you would want close observation, and vitals essential at this phase because it's at this postictal phase where most fatalities occur. So generalized absence seizures. Absence seizures are most common in children. They're very rare after the age of 20. There definitely is a genetic tendency for absence seizures. There's a very brief change in the level of consciousness signaled by blinking or eye rolling. They will have like to be sitting in a classroom or sitting in your operatory chair, and just all of a sudden they can start blinking or eye rolling and then just have this blank stare. So it can last like 5 to 30 seconds, or it could be up to 100 times a day that they could do this. There's very minor facial movements, just the blinking or mouth movements. Amnesia of the episode, and then as soon as that 5 to 30 seconds is up, they just return to normal play, and is what usually happens, but it could even progress into a tonic-clonic stage where they're doing stiffening and then jerking. If these are not well controlled or factors exist which would predispose the patient to a seizure that day, treatment should be postponed until they're way more stable, obviously. But for these type of patients, if you are going to treat them, early morning appointments are best. After a meal and within a few hours of taking medication is the optimal time for treatment. Sometimes you need the use of a mouth prop during treatment, and if they have dentures, then you want to remove the dentures, are always recommended for if they're going into any type of a seizure. You want to remove anything loose that's in the mouth. But they used to say back in the day that to use a mouth prop kind of as a bite guard so they wouldn't bite their tongue. And that's what they wanted to do. They don't recommend that anymore. They just recommend using a mouth prop during treatment to keep their mouth open. But naturally, if they're having some type of seizure, you want to remove everything from the mouth. So treatment of generalized tonic-clonic would be primary task is to protect the patient and try to prevent injury before, during, and after the seizure. You want to stop all dental treatment, and like I said, remove the instruments and mouth prop from the mouth. You want to scoot all of the equipment out of the way loosen their, if they have tight clothing, so they can breathe easier. And contact EMS first, unless instruments are in the mouth, in which case you would remove everything from the mouth and then contact EMS. That goes back to sometimes they will differentiate on what you do first on test questions. So you place them in a supine position. You want to lower the dental chair and leave the patient in the dental chair. So if they're going to start to have a seizure, we don't want to move the patient to the floor. We want to prevent them falling by positioning one person at the head of a chair and one at the foot of the chair. And then they can try to administer oxygen like 4 to 6 liters per minute. So you're just wanting to, you don't want to heavily restrain them because they will fight back. You just want to gently restrain them from maybe flopping onto the floor. You want to do your CABs of CPR, maintain the open airway, and monitor their vital signs always. Gently restrain to prevent injury. Do never forcefully restrain, as this can injure limbs, either yours or theirs. And not to place anything in the mouth. Definite test question. Don't place anything in the mouth. Postictal treatment is critical. Muscle flaccidity is common, which is meaning complete relaxation. So you need to protect the airway is vital. Reassurance to the patient and being calm would be really good. These patients, after they have had this, should never drive themselves home. He or she should be released to a responsible adult. You may call their emergency person or their contact person that they hopefully give when they're a patient in the office. So then we have something called status epilepticus, which it's just me, but it always reminds me of like Spartacus back in the Greek days or something. But this is status epilepticus. It is a continuation. It's when your tonic-clonic or repetitive recurrence of any type of seizure continues. It just keeps continuing and continuing without there being a recovery in between episodes. It just keeps going. It's extremely life-threatening. It could even persist for hours or days. The mortality rate is 3 to 23%. And during this time, their temperature could rise as high as 106 degrees Fahrenheit. These people, of course, if that tonic-clonic is not stopping, you hadn't called 911 before, you would definitely be having someone call 911 or EMS to get there fast. So tachycardia and dysrhythmias are involved. Higher blood pressure, it could even go as high as 200 on a systolic over 150. Death occurs due to cardiac arrest. Irreversible brain damage can happen to cerebral hypoxia. So that would just be less than normal air to the oxygen to the brain. So immediate medical intervention is required to prevent death if they have status epilepticus. Epilepticus. So they need an IV, which is an anticonvulsant drug therapy, and that is something that we cannot give them, that only a hospital can give them. Possibly, I don't know everything that an ambulance or an EMS has in their arsenal in their truck, but if they could start something there, they probably do, and then transfer it into the hospital. So you want to stop dental treatment for the duration of the episode, if they're having, of course, an episode. Protect the airway, remove instruments from the mouth, monitor vital signs, and then sometimes, depending upon, like if they have an absence seizure where they just blank out for minutes to maybe 5 minutes, and all of a sudden they come back, they're very normal. I mean, nothing, they don't maybe even remember that happened. And they will ask, can we please continue the treatment? I work, I can only get this time off. I've driven 40 miles. I don't want to do it again on another day. And if they're okay, then you can go ahead and continue treatment. There's no problems with it. So control of seizures with the fewest side effects is kind of the goal, is to be able to do that and have had decrease in seizures due to new medications. So this is something that has brightened everybody. For the very longest time, there were only a few medications, and that was it to choose from. So if those particular medications didn't work for you, then you were kind of like out of luck. So now they have newer medications. Drug therapy eliminates seizures in about 1/3 of patients, and it greatly reduces the frequency in another 1/3. So that's great news, and we're just hoping that we even get better news in the future of even more helpful drug therapies. So these are 60 to 80% are in good seizure control. That says a lot.